Hi, everyone, and welcome. And I know, it's pretty much noon on the dot right now, so people will filter in. Please feed yourself and all of that as you come in. So thank you very much for coming. So for those of you I have not yet had a chance to meet, my name is Odette Lino, and I'm the new dean here at BC Law School, and really thrilled to be here. I'm very new. In fact, I just started last week, though I've been meeting with various people over the course of the fall and have really enjoyed the chance to get to know the school, the community, and learn what's most important to all of you. And I'm especially thrilled to be here and be able to introduce this event, the human right to access vaccines, and especially the case of COVID-19. I feel that this particular subject really represents several really important parts of the BC Law mission, the Jesuit mission of social justice, of care for others, and of serving the greater good, and also international human rights, including the access to health care for all. As some of you may know, but I'll just share also that a large part of my own research and scholarship has to do with international law and global norms, and in particular, has to do with grounding the rules and norms of the international arena in a commitment to furthering the greater good, and especially to understanding individuals and human communities as the ultimate center of concern and attention. My own focus is more in the area of sovereign debt and international finance, but I'm really interested in how this translates across all of the different arenas, and of course, global health and access to health is such a foundational element for everything else that happens in the world. And really also one of my longer-term goals for BC Law is to expand international curricular and extracurricular programming, especially in the area of human rights and in our international partnerships and partnerships with other institutions. So our global programming featuring events like this is very important to me, as I know it is to our faculty, staff, and our students. I also wanted to say how grateful I am, and we all are, to partner with two prominent university centers, the Center for Human Rights and International Justice, and also the Schiller Institute's Global Public Health and the Common Good program. I'm especially pleased that this just happened to be the first major event that I have the chance to attend and introduce as the dean, and so that's exciting for me, as university cross-disciplinary work and collaborations is another important goal of mine. So I know you're all waiting for the main event, and I won't take up more of your time, and I'd like to thank everyone involved, including our distinguished panelists, Lisa Forman and Phil Landrigan. Phil, nice to see you. Hello, over Zoom. And of course, our own Katie Young, who is our professor and associate dean for faculty and global programs and will be moderating. So I'm going to turn over the mic to Professor Young, who's going to be introducing the panelists, and I look forward to the discussion and to meeting some of you. Thanks again for coming.
Thank you so much, Dean Lineau, for launching this incredibly interesting talk. Here in Boston, we can sit back and think about COVID-19 and think about vaccine resistance, misinformation campaigns, what we're seeing in the wars around masking and so forth. But of course, there's a global moral catastrophe underfoot, which is a lack of access to the variability to find a vaccine, to be given a vaccine in much of the world. This has variously been called vaccine inequality, even vaccine apartheid. And it's wonderful to have our two speakers offering their perspectives, both on the international human rights implications from Professor Lisa Forman, and also an incredibly and profoundly great experience with vaccine from Professor Phil Landrigan at the Schiller Institute. So I wanted to introduce our speakers very quickly. Unfortunately, Professor Landrigan is with us only via Zoom. I mentioned this irony to him today. He wouldn't mind me mentioning, for the reasons of ill health and the fact that vaccines are not 100% effective in preventing disease, but of course they're effective in minimizing the effects of the disease and minimizing the consequences of catching it, as well as helping prevent it. So he's going to give us a very wise perspective over Zoom on vaccines in general. So let me introduce him first. He will speak, and then I'll introduce Professor Foreman. So it's my great pleasure to give some biography to Professor Landrigan here. He's a pediatrician, a public health physician, and an epidemiologist who, as I mentioned, is a director of the Global Public Health Program and Global Observatory on Planetary Health. I didn't mention that, actually. That's what he directs, but he's also a member of the Schiller Institute for Integrated Science and Society. Professor Landrigan has an incredible experience. As a young doctor, he worked with the CDC, involved in the campaign to eradicate smallpox, and he was involved for 15 years in a campaign in Nigeria. He understands the efficacy of vaccines in a way that we are really happy to have in the room. He also has a long experience dealing with such public health problems as lead pollution, in fact, leading efforts to inform the US government about the effect of lead on child populations. And his work, which he co-led with the late Herbert L. Needleman, led to the government's decision to remove lead from paint and gasoline. Actions that reduce the population mean blood lead levels in the US by more than 90%, an incredible public health intervention. I can list many other interventions he's made throughout his career, including looking at the susceptibility of children to pesticides, and now presently looking at the effect of pollution on particular populations, working very closely after co-chairing the Lancet Commission on Pollution and Health, co-chairing that from 2015 to 2017, and now continuing that work at Boston College. So it's fantastic to have him give his perspective on the vaccine questions surrounding COVID-19, and I'll move to Phil to perhaps share his screen with his slides if he would like, and run through his talk. Is that possible to share the screen, or?
Yes, I'll just talk for a quick second and then I'll share the screen if I may.
Okay, wonderful, thank you.
Thank you, Katie. Thank you, Dean Lineau, for hosting this. Ironically, the reason I'm with you on Zoom and not in person is that I myself am in my 4th day of a COVID infection, despite having had my 3rd dose of vaccine as recently as September. But I just want to say what a pleasure it is to be at the law school. Our program for global public health and the common good has had a strong relationship with the BC Law School since I arrived here 4.5 years ago, and it plays out on at least 2 fronts. First of all, 2 of your distinguished professors, David Worth and Marianne Sherba, co-teach a very, very important, highly well-received course each year in public health law, which is a core component of both our undergraduate minor and our new undergraduate major in global public health. And then more on the research side, since my research deals with pollution and its impacts on health, no surprise, a long-running relationship with the environmental law program at the law school, and it's an association that I personally treasure, but it's also an association that's programmatically very important. So with that, by way of intro, let me share my screen. Sorry, I'm disabled for screen sharing. I need somebody to push a button. I thought I was good because the icon was there, but
How about now, Phil?
I'm now good. Yeah, thanks. All right. Oops, sorry, wrong button. Right, okay, so here we are. So I'd like to, this will be very quick. I see myself as setting the table for Professor Lisa Foreman, who is certainly the main attraction here today, but Tim and Katie and I thought that a brief overview on vaccines and their importance in public health would be a good way to begin the session. So I think the single most important point I want to make today is that vaccines have been an incredibly powerful tool for preventing disease, in people of all ages and in people in countries at every level of income around the world. Just a few of the successes. I can't possibly list them all, but the one in which was really one of my points of entry to public health was the global campaign for the eradication of smallpox. Smallpox was a dreadful disease. I'll show you a picture in a moment. It used to kill millions of people per year. And in the 1970s, through a joint effort that was coordinated by the World Health Organization and then involved the USSR and the USA, we had endless supplies of vaccine available at no cost to host countries. We were able to mount campaigns in some of the most desolate places in the world, and we have eventually eradicated this disease from the face of the earth. It only exists today as a specimen in a couple of laboratories, one in Atlanta, one outside Moscow. Another disease that was eradicated, the only other one that was truly eradicated, is a disease called rinderpest, which is related biologically to measles. It's a disease of cattle that used to wipe out cattle, which are a source of life and income in rural Africa. Vaccines have brought about huge reductions in a whole series of diseases that I've listed here, and this is only a partial list. They've reduced deaths from liver cancer because the combination of hepatitis B infection and exposure to a toxic chemical called aflatoxin is a potent cause of liver cancer, and when you can suppress the hepatitis V, you prevent liver cancer. HPV vaccine, human papillomavirus, has brought about enormous reductions in deaths from cervical cancer and oral cancer. And of course, most recently, and I would say that I'm living proof of it, even if I'm feeling pretty uncomfortable today, that the COVID-19 vaccines have brought about more than a 90% reduction in mortality. At my age, 80, if I had gotten COVID 3 or 4 years ago, 3 years ago, before the vaccines came along, there's a very high likelihood I would not be making this presentation to you today. And instead, I'm already slowly on the road to recovery. So here's a couple of pictures. This is smallpox. Smallpox was a dreadful disease. Those pustules that you see all over the body of this poor man were also would be found in his lungs, his liver, his internal organs. And it was just overwhelming viral infection caused death from the disease. The last case was in Somalia, no surprise because there was a war going on there at the time, but we got vaccine teams in, eradicated it in 1977, and the official declaration was 2 years later. A couple of other diseases that vaccines have greatly reduced in frequency. Measles, which sounds like a small disease because of the name, it's not. The typical fever was 106 degrees. 1 in 10 children got an ear infection, 1 in 100 got pneumonia, 1 in 1,000 got a brain infection, often leading to permanent brain damage. In chronically ill and malnourished children, it's a killer. In the aftermath of the Nigerian Civil War, measles swept into the camps, the concentration camps in Nigeria, and the death rate for measles there was 50%. Polio, which causes paralysis of the legs, is way reduced from around the world, but this is a picture I took when I was working as a primary doctor in Ghana a few years ago. There are still cases in places in almost all in low and middle income countries or in isolated populations in this country where for various reasons people decline to take the vaccine. Vaccines are highly cost effective. Don't want to belabor it except to make the point that they not only work, but they save enormous amounts of money. The World Health Organization did a study that was published a couple of years ago looking at 94 countries around the world, 10 big vaccines, and they found that the return on investment was between 20 to 1 and 26 to 1 for every dollar invested. And in New York City, Yale University researchers just did a study last year looking at the ROI on vaccine against COVID, and they calculated a minimum ROI of 10 to 1, which derives really from savings in 2 areas: reduced healthcare costs, number 1, and secondly, reduction in the productivity losses that occur when people are taken out of the workforce by disease or premature death. So if you're trying to put together a vaccine campaign, if you're at the World Health Organization or the CDC, there are several elements that you need to have to make the thing work, to really get the vaccine out there. First and foremost, of course, there must be a vaccine that is safe, that's cheap, and that is effective. I should say quite clearly, no vaccine is completely safe. For example, the measles vaccine produces a serious adverse effect in somewhere between 1 in 10,000 and 1 in 100,000 children who get vaccinated. Other vaccines have similar low rates of adverse effects. It's not zero. But when you compare the extraordinary devastation caused by the wild disease with the rare, sometimes serious, but very rare complication of vaccine, the risk-balance ratio is tilted very, very powerfully in favor of vaccination. The second thing you need if you're going to have a vaccine program that works is you need a disease surveillance program that in real time or near real time tracks the time course and the geographic distribution of cases. That way you can get vaccine teams out and you can vaccinate in a ring around a case. That's how we eradicated smallpox. Thirdly, you need people. They don't have to be fully qualified doctors or trained nurses, but they have to be people that know what they're doing, who know how to give vaccines, who know how to do what's called preserving the cold chain, which is keeping the vaccine cold until it gets into the patient's arm. You need to have a very carefully thought through delivery strategy that goes the last mile, gets that vaccine out to the most isolated community in Appalachia or the most deeply rural village in sub-Saharan Africa. And there need to be education campaigns that take advantage of local cultural icons to spread the word that vaccines are important. This becomes especially important, of course, when there's deliberate disinformation. We can talk about why some people take great pleasure in putting out vaccine disinformation. But whatever the motives, it's important to counter it. You have to have funding. And then finally, which leads into Professor Foreman's talk, there need to be financial mechanisms in place and legal and policy mechanisms that allow people in every corner of the world at every level of income to get access to the vaccine. There's no point in having a great vaccine and a great vaccine program and no access. And I'll close with this slide from a dear friend and colleague, Agnes Binouaho, the former health minister of Rwanda, who told me when we were talking a few weeks ago that it was just absolutely dreadful to see people. She didn't begrudge the fact that people in the high-income countries are receiving a second shot and a third shot. She's a good doctor. She understands that multiple vaccines are necessary. But it wounded her to the core to realize that she couldn't even get a first dose of COVID vaccine for most of her population in Rwanda. So that concludes my little presentation. I give it back to you, Katie.
Thank you, Phil. Next, I'll introduce Professor Lisa Forman, who comes to us from the Dalai Lama School of Public Health at the University of Toronto. I've known her work for many years, her work on the right to health, international human rights law, and global health generally. She holds a Canada Research Chair at the moment in human rights and global health equity. Originally from South Africa, she was educated first at the University of Witwatersrand in Johannesburg, receiving a law degree there before moving to receive an LLM at the Columbia Law School, or a Master's in Human Rights Studies at Columbia University, and then an SJD at the University of Toronto at the Faculty of Law. So she joined the School of Public Health in 2009, has published an extremely large amount of work, often in interdisciplinary studies around human rights and the right to health. So let me welcome Professor Foreman.
Thank you.
Right there. I guess he is the other.
Oh, okay. Oh, it's not attached. Okay. And I can push slides with this?
I tested that, so that should work.
I can use this. I think that's the wrong one. Let me do the one where. Yeah, you can all see. Okay. Good afternoon, good morning, good afternoon, everybody. It's absolutely a pleasure to be here. Thank you, Katie, for that lovely introduction. And I'm delighted to be here. It's wonderful to see the extent of interest and excitement in this topic. And I'm really, really thankful for the invitation to talk to you all today and for the co-sponsorships from the Center for Human Rights and International Justice and from the Schiller Institute. I thank you, Professor Landrigan, for that incredible introduction from a public health perspective of the importance of vaccines to public health. And I think it's a wonderful way in which to move into a discussion of the legal framework for a human rights claim to vaccines as part of a broader claim to medicines within the right to health. So I'm a legal scholar. I focus on the right to health in international human rights law and what that right implies for what states and other actors should do when it comes to policy, programs, and actions that impact on people's lives and health. And I came into this work through graduate work on human rights campaigns for affordable antiretrovirals in sub-Saharan Africa. As Katie said, I'm South African. A lot of the human rights campaigns around affordable antiretrovirals took place in South Africa. And that work really looked at the implications of the right to health in international law for what states and other actors should be doing when it comes to affordable medicines, and particularly what the implications were for pharmaceutical patents under the WTO, World Trade Organization, protections in the TRIPS agreement, the agreement on trade-related aspects of intellectual property rights. So what we saw in those campaigns for access to affordable antiretrovirals was probably one of the most successful health and human rights campaigns that has occurred. Human rights actors and mobilization, litigation, arguments were able to produce really simply extraordinary shifts in global policy, in global governance, in institutional approaches to the question of access to antiretrovirals in low and middle income countries globally, and in the interpretation and the enforcement of pharmaceutical patents under TRIPS. And they were very formative in the broader development of the notion of a right to medicines, a human right to medicines. And most importantly, what we saw from those human rights campaigns for affordable antiretrovirals was really extraordinary material impact on the ground. So what the graph here is something that shows the way that as access to affordable antiretrovirals went up from really almost nothing in the early 2000s to close to 30 million people today. As access to the treatments went up, AIDS-related morbidity and mortality just fell precipitously in low and middle-income countries in the same way that it had in everywhere that antiretrovirals had been introduced. And where we saw not only illness and death from HIV reduce, but prevention, the transmission of HIV infection reduce as well because of the extent to which antiretrovirals impact on transmissibility of HIV. So this was an extraordinary human rights success, but it's incredibly disheartening that in the COVID pandemic, the experience seems to have counted for almost nothing when it comes to how access to COVID vaccines has rolled out. So during COVID, we've failed really quite thoroughly to ensure the equitable distribution of COVID vaccines globally to all countries. The majority of the vaccines, as you can see in this graph, the majority of those vaccines have gone to wealthier nations, and very, very few have gone to low-income countries, with the fewest vaccines going to the African continent. And the reason for this, I'm not going to delve into it too much in my talk today, but the reasons for this are intimated in that quote from Agnes Benweo in Professor Landrigan's presentation. It's largely because high-income countries have bought up as much as they can of available vaccines and hoarded those vaccines, and there simply hasn't been enough to go around for everybody else. At the same time, there's been inadequate philanthropy to the COVAX mechanism, which was created at the UN precisely to avoid this situation. Countries have just not donated sufficient money or sufficient amounts of vaccines to the COVAX mechanism. And countries have had their hands tied in terms of producing the vaccines themselves, both because there's been very limited manufacturing capacity in low and middle income countries, particularly for this type of vaccine. And there's been tremendous amounts of legal and political opposition to loosening those intellectual property rights that pharmaceutical patents are protected by. Particularly when low and middle income countries pushed for a waiver of the TRIPS agreement when it comes to COVID-related diagnostics, medicines, and therapies for the duration of COVID. And I think, what we see here is that the disparities really mirror the inequitable distribution of antiretrovirals under HIV before the successes of human rights campaigns interrupted this dynamic. So what I'm going to do in my talk today is really focus in on how we should view these kinds of disparities from the perspective of human rights, and particularly from the perspective of the right to health and international law, and delve into the ways in which the right to vaccines and medicines is being developed in international law, and the way that there's some evidence of some uptake of this right in a variety of places. I'll close then by considering some indications of where we may be going with this right, particularly in terms of the negotiation of a pandemic treaty at the UN over the next couple of years, which may fill in some of the gaps and may or may not offer some ways to boost the legal claim for a right to medicines. So many of the themes that I'm talking about today are picked up in a special issue of Health and Human Rights Journal that was published in December last year, that I co-edited along with the absolutely wonderful professors Katrina Perehudoff and Carlos Correa, and which explores vaccine equity and human rights from a range of different perspectives. They're really fantastic papers in there. We're funded in that work by a very generous grant from the University of Toronto Connaught Global Challenges Fund. And the paper, the talk that I'm going to be presenting today draws somewhat from the paper that I published in that special issue, which delves into the legal status of a right to medicines and vaccines under international human rights law. And it uses the interpretive framework of, if there are international law scholars here, what I'm about to say will be exciting to you and probably nobody else. The paper uses the interpretive framework of the Vienna Convention on the Law of Treaties, on the interpretation of treaties, and a 2018 International Law Commission report on the way in which we might be able to understand when states have agreed through actions or practice to change the interpretation of a treaty. And I'm not going to go into the legal intricacies of that paper, but I'm going to really draw back from that very, very focused legal inquiry to ask the more general question, which is there a right to vaccines and medicines in international human rights law? So from an international human rights law perspective, there are a range of human rights that are codified and protected that would impact on a person's ability to access a life-saving, life-sustaining medicine or vaccine, from the right to life, to equality and non-discrimination, to bodily security. But really, the primary home for that claim lies in the right to health in international law, which is extensively and expressly protected in a range of international human rights treaties and has been since the inception of the United Nations. So the earliest recognition of a right to health in the international sphere comes in the Constitution of the World Health Organization, which established the WHO, where the right to health is recognized as a fundamental human right. It's also recognized in the iconic Universal Declaration of Human Rights from 1948, which really is the foundation of the international human rights law system, where the right to a standard of living adequate for health and well-being is recognized. That includes and extends to medical care. But the most authoritative expression of the right to health comes in the International Covenant on Economic, Social, and Cultural Rights, which recognizes everyone's right to the enjoyment of the highest attainable standard of physical and mental health, and specifies a range of steps that states that sign on and ratify that treaty are bound to take in realization of that fairly amorphous and very aspirational standard, from addressing infant mortality and healthy child development to preventing, treating, controlling disease, and the catch-all of assuring medical services and attention to the sick. You'll find very similar wording to this in later international and regional human rights treaties that also entrench rights to health and well-being. That includes medical care, from the Convention on the Rights of the Child to the Convention on the Elimination of Discrimination Against Women, to some of the regional instruments, the African Banjul Charter on People and Humans Rights, and the Protocol of San Salvador on Economic, Social, and Cultural Rights in the Inter-American system. So I think what you probably can see just from this text is that medicines and vaccines are not specified as part of the right to health. But I think it's very hard to argue that medicines and vaccines shouldn't fit into either parts of this article, and certainly into Article 12.2. You know, on the one hand, the wording of Article 12.2 is clear that it includes these steps. It's not limited to the steps specified. And on the other hand, almost every step specified here would necessitate, to some extent, the provision of medicines or vaccines, whether we're addressing infant mortality and healthy child development, or preventing and treating disease, to assuring medical service and attention to the sick. So if this is the case, if it's so logically, commonsensically fits into it, why was it not specified in the drafting of the International Covenant? I think one explanation for that is that when the International Covenant was being drafted between 1948 and 1966, an extraordinarily long period of time to draft a treaty for historical reasons that we can maybe touch on in discussion, which I'm sure all of you know very, very well, in terms of the tensions of the Cold War and how that played out in the interpretation of human rights and of economic, social, and cultural rights specifically. In that time frame, for a period, 1948 to 1966, medicines just simply wasn't considered as an explicit part of the right to health. And if you go back into the drafting records, you'll never find the word medicines used to refer to pharmaceuticals rather than to the practice of medicine or to the provision of medical treatment. You'll never once find the word pharmaceutical or medication. And to some extent, I think this really reflects the state of medicine at the time. Just to give you some sense of the historical context, the first WHO essential drug list, which was a really important move in terms of articulating the imperative, the priority of essential medicines, that was only created for the first time in 1977. And the golden era of the discovery of antibiotics was in the 50s and 70s. So the drafting of this provision really preceded some of those medical innovations. And in the same way that the drafters of the International Covenant didn't understand that they might need to articulate a right to water and sanitation, it wasn't in anyone's mind that water could not be anything other than an infinite resource. They didn't understand that you might need to articulate a right to a clean and healthy environment either. So too were medications and medicines just not in the covenant. And it fell to subsequent interpretations to read medicines, as with water, as with a clean and healthy environment, to read those into the International Covenant. And I think we can say with some certainty that at the international level, in terms of the human rights committees, etc., absolutely definitively, medicines and vaccines have been read into the right to health. particularly through a range of authoritative comments, general comments on the International Covenant on Economic, Social and Cultural Rights, issued by the UN Committee on Economic, Social and Cultural Rights, which oversees that treaty and the interpretation of its rights. So if you are interested in the right to health at all, the General Comment 14 on Article 12 on the right to health is an incredibly important development in how we understand the right to health. Right now, now to say that something that came out in 2000 is recent or groundbreaking maybe sounds like it's part of ancient history, but before 2000 we didn't have an authoritative interpretation of this right. And General Comment 14 did a lot of very, very important things. It clarified a lot of the vagueness and confusion around this right. Said it's not a right to be healthy, it's the right to very concrete things, a right to adequate, affordable, good quality, medically appropriate, culturally appropriate healthcare, and to the underlying determinants of health, something, narrow a slice of what we maybe more broadly understand as the social determinants of health. And within that interpretation, there's a lot of focus on access to medicines and essential medicines as an incredibly important part of the right to health. It's identified as a core obligation, as an essential element, as really a prioritized aspect of that right. Another really important interpretation came in 2006 when the committee interpreted another part of the covenant, Article 15, on authors' rights and the right to benefit from scientific progress. And the timing is also fairly significant. This comes after the access to antiretrovirals campaigns have played out. And here the committee said that if we are talking about intellectual property rights and human rights, we need to differentiate between intellectual property rights are not human rights. And that intellectual property is an important social product with a social function, and that states have a duty, because of that social function, to prevent unreasonably high costs for access to essential medicines from undermining the right to health of large segments of the population. So the right to what we now are terming the right to science, this Article 15 has become an incredibly important other part of the international covenant when it comes to vaccines and medicines. Insofar as it doesn't just articulate a right to benefit from the protection of moral and material interests when you've produced scientific, literary, or artistic production, but also talks about people's right to enjoy the benefits of scientific progress and its applications. And I don't think it's a coincidence when you consider the broader context, what was happening, that this comment came out in 2020 as COVID was hitting. Now, General Comment 25 extensively interprets this part of Article 15 and does in ways that is incredibly relevant when it comes to talking about a right to vaccines. And what the committee does there, it reiterates, states have duties to ensure access to vaccines, to ensure that there's not unreasonably high prices for them, and that they have duties more broadly to promote scientific research, to make new medical applications accessible and affordable to everybody, including by limiting the impact of intellectual property rights in a range of different ways. And certainly during COVID, the committee has moved to very explicitly articulate a right to access safe, effective, affordable COVID vaccines as a derivative of the right to health and of the right to benefit from scientific progress. And they've gone further than anything. They've been responsive to the disparities that we've seen and have urged states in a range of different ways to take steps to limit the restrictive impact of pharmaceutical patents in a range of different ways. So what we see with this broader range of comments and interpretations is the committee stepping in to fill this gap fairly definitively, saying this is absolutely a part of the right to health, a part of the right to scientific progress, and scoping out the normative content and the scale of state duties when it comes to these rights. general comments and statements are persuasive and authoritative, but they're not binding. So where do we stand more broadly when it comes to a right to access vaccines and medicines? So one place I think we see the broader development of this right is that increasingly the rhetoric of access to affordable medicines as an essential part of the right to health has become very common, increasingly common in domestic and global policy and law, whether we're talking about the UN Global Health Policy on Sustainable Development Goals or the constitutionalization of the right to health at the domestic level. So there's been an incredible relative explosion of right to health litigation on medicines claims around the world. We've seen the right to medicines increasingly codified in national constitutions, often as a part of the right to health, and incorporated not in rights language, but in terms of the normative concept that everybody should have access to affordable medicines and vaccines in the Sustainable Development Goals on health. There have been a proliferation of reports at the international level on the imperative of universal access to affordable medicines. And these aren't necessarily linked to the committee's interpretation as much as just really indicating that we're in the process of evolution and movement around broader recognition of this right. Certainly one important indicator of where we stand is that there's been a tremendous growth in resolutions coming out of the UN Human Rights Commission and the UN General Assembly on this topic. And the General Assembly is a really important place to look because there you have all states participating. And if they vote in consensus or in unison on something, it reflects certainly some extent of state agreement. And here we've seen a litany of resolutions coming out of both those bodies that recognize access to medicines as part of the right to health and then later as part of the right to science. From early recognitions that access to medicine in the context of AIDS was a fundamental part of the right to health, obviously contemporaneous with those struggles around access to antiretrovirals, to broader recognition of a right to health that includes access to medicines. And during COVID, there's been this broadening out into UN General Assembly resolutions that recognize a right to access vaccines as part of the right to health and part of the right to science. Not unanimously consented to, though. There's some extent of disagreement on that. But there is certainly the weight of state consensus seems to be to recognize access to medicines. Another really interesting place for where we may see some extent of recognition of a duty to assure access to affordable medicines and vaccines when it comes to pandemics is in the pandemic treaty that's being negotiated right now. So the pandemic treaty is a new international law treaty that's going to attempt to fill in some of the gaps that we've seen in international law when it comes to pandemics. And that will we don't know what's going to be in the zero draft of this treaty. It's literally being drafted as we speak. It's going to be issued in, I think, early February. There's been a range of different preliminary drafts that have come out, including this conceptual zero draft, which confusingly is not a zero draft. I think it's supposed to just provide the concepts that could guide the zero draft. We don't know what will be in the zero draft. But this gives us a little bit of an indication of certainly some of the places that are going. And it's very interesting from the perspective of this discussion to look at, well, how is the right to health? How are affordable medicines? How are IP addressed in it? So it's as a snapshot of where things are, I think it tells you exactly where we are. So the right to health is recognized as in the preamble to the conceptual zero draft. It's recognized as one of the principles that should guide the zero draft. And there's recognition not connected to the right to health, but as part of a principle on equity that an effective response requires equitable access to affordable, safe, efficacious pandemic responses, which is very, very much the language of the right to health and the right to medicines. And there's this freestanding duty to assure timely access to affordable, safe, effective pandemic response products, including vaccines. Very explicitly disconnected from the articulation of the right to health. There is no connection being made here in the language between the right to health and a duty to provide medicines. But the fact that there are these recognitions of state duties to ensure timely access to affordable medicines in very much the same language as you'd find in the human rights interpretations, I think reflects the normative imprint of the right. There are several places also in the conceptual zeros draft which try to broach that tension between the protection of intellectual property rights and their impact on pricing and access to medicines. And I just snapshotted some of the provisions, the options for provisions. This comes from the preamble. It's not even an actionable item. It's literally just those pieces in the preamble that recognize the context and recognize some of the broader issues. So these are all the options that have been provided for how drafters, negotiators might address the impact of IP on access to affordable medicines. I'm not going to go into the details other than to just show you this. Here you can see very, very clearly the extent of contestation and political contestation and debate that is anticipated around this particular piece here. So I think in as much as the pandemic treaty is an opportunity to turn the right to medicines into a hard, legally binding right, I think that the broader politics of access to medicines and of intellectual property rights are very likely to prevent that outcome and to prevent the pandemic treaty from meaningfully linking access to medicines and vaccines to the right to health, or from addressing the impact of intellectual property rights on affordability and access beyond anything that has already been agreed to at the international level. But I think even delinked duties to assure affordable access to medicines within a binding legal treaty would be a very welcome move towards recognition of a legally binding right to medicines. And I think irrespective of what happens with the pandemic treaty, if we draw back out to the bigger picture around this extraordinary amount of movement towards recognition of the rhetoric of access to affordable medicines as a right, I think we can maybe hope that we're really in the middle of an evolutionary process that is nowhere near completed. So I'll end there. Thank you.
We have about 11 minutes for questions, so I open your questions. Professor Barroso.
Professor Foreman, thank you. So, a practical question. Let's stipulate the existence of the international human rights, vaccines, in the context of a pandemic.
Yeah.
And put that to the side. So, what duties the United States should have discharged at the stages of development, acquisition, and distribution in compliance with that right?
I mean, that's absolutely the question, and it's the most complicated question because the U.S. alone amongst many countries when it comes to economic social culture, as you all know, does not sign on to and ratify these treaties. So let's acknowledge that giant elephant in the room that the U.S. Talking about the right to health and economic, social, and cultural rights in the U.S. is a uniquely difficult legal argument to make. On that, I'll simply say that at this stage, within liberal democracies more broadly, the U.S. is an outlier from the perspective of its de facto and de jure recognition of a right to health. But let's put that enormous piece to the side. What should the U.S. have done? I think that applies irrespective of whether we're framing this in the context of a right to health, whether we're talking about principles of equity, of common and differentiated responsibilities when it comes to pandemics, the principles of solidarity and cooperation that ostensibly are supposed to drive international coordination, there should have been, in a range of different countries, and I put Canada here as well, because Canada, quite frankly, was one of the worst actors when it comes to hoarding vaccines. Countries should have paid greater attention to the needs of other countries. Now, I recognize I say this, we all just lived through COVID. We saw what happened outside of the extraordinary politicization of COVID. In a lot of countries, all norms of equity and access and affordability went, and what are my duties to those outside my borders? That just fell off completely off the radar, and that is as true in Canada, which likes to think of itself as a human rights defender globally. So this is not simply an issue of, the US, which isn't a proponent of economic, social, and cultural rights, but what happens in a crisis and what drives decisions in crisis. I think we can all probably say that coming out of the last couple of years, it's absolutely the opposite of what you'd want it to be. Equity, rights, fairness, they just don't seem to be in the picture. So I don't know if I think my answer is we could have hoped for something better, but we didn't see it, and we didn't see it from almost anybody. Yeah.
I think at the very least, one would hope that a country that sees itself as complying with a right to health, that might, for various reasons, not include the United States at the present moment, would not object to the TRIPS waiver proposal, which would mean that intellectual property rights would be waived for public health reasons. And the prominent countries include Canada,
Yep.
Norway, Japan, the UK, Switzerland, and Germany, and the EU as a whole, objecting to the waiver. I see a lot of human rights students here. I hope there are a lot of IP students here, because if that waiver takes place, these vaccines become much easier to access. Of course, there's a whole numbers game as well as a cost game, but that's the financial implications. I see another question, Professor Katz.
Yeah, thank you so much for the presentation. It's incredibly important, and I learned a lot. I have a sort of methodological question about how this vaccine issue relates to other sorts of rights claims. And some of this comes out of ignorance, I will confess, but it strikes me that thinking about vaccines is often rather utilitarian in terms of a trade-off between or among efficacy, cost, and side effects, so that you could have like the Sinovac vaccine as compared to Moderna. And I wonder how we calibrate that as we're thinking about the rights, the distribution questions, and so forth. Because it seems to me that's a very complicated thing to build into a rights framework.
And I think you're right to pick up on the extent to which the rights framework doesn't necessarily get into some of the more granular parts of what you'd need for equitable rollout. And I don't know that rights necessarily claims that it's the answer to assuring equity in this context. I know that in the context of COVID, there's been an extraordinary amount of recourse to ethical bioethics and other conceptual frameworks to drive some of the more of the granularity, for sure. But I was very struck by Phil's slide on, what are the hallmarks of an effective vaccine program. He could have taken that straight out of General Comment 14, in terms of identifying affordability, accessibility, good quality, culturally appropriate. So I think there are really important pieces, is certainly around non-discrimination and how we should understand when it comes to rollout. I think sometimes the human rights piece has more to say about what happens between countries to some extent. Certainly it has a lot to say about what states should do with their own populations, but it's a partial picture, for sure. Yeah.
Thank you.
Okay, any more questions? Not, I have one of my own. I guess I read out a list of countries, and we can kind of think of the colonial origins of these countries. You can also demarcate them on certain racial axes. And I just wondered where you saw the historical, I guess, aspects of the UN system, the Universal Declaration of Human Rights, the later covenants being split into economic, social and cultural rights and civil and political rights, and the different take-up according to geopolitical interests and the like, where you see that history speak to the present moment, and whether a kind of reparations frame or another way of dealing with that history could be more efficacious in these vaccine debates. And I launched, the discussion with talk of vaccine apartheid. I think that phrase has been chosen deliberately. But do you think something more that casts back to the origins of the very moment of coining human rights is needed?
I mean, I think you're 100% right to ask those questions and to ask the extent to which contestation of economic, social, and cultural rights, broader misuses of the human rights framework or divisions between civil and political and economic, social, and cultural rights, how that's intertwined with colonialism. I think and neoliberalism, really, quite frankly. I mean, I think if you were to look at the list of countries that are consistently oppose leniency on intellectual property rights, you'd find there's a very strong connection between those countries and the multinational pharmaceutical companies. They're protective of what is a key economic industry within their countries. So I think how do you pass that all out and separate that is, I mean, I think within the human rights field, we're very, very engaged with trying to figure out how does colonialism play into this. I think we've been struggling, grappling with questions around neoliberalism, but this move towards a decolonial interpretation of international human rights law, I don't think human rights has really grappled sufficiently with what that looks like. I mean, certainly one of the interesting things here is the way in which the right to health is seen as a viable and important piece of some of these moves. India and South Africa, when they asked for the TRIPS waiver, they didn't specify necessarily immediately the right to health, but it came out in later discourse. There's a really cool and interesting paper in the special issue by Katrina Perahudoff, and also one by Gillian Kohler, that looks at the discourse around the TRIPS waiver and where human rights was used and where it was not. So would it be more effective? I don't know. I mean, I think it's important. I certainly think that it's something that gives a different way in which to recognize, who consistently stands against more lenient IP. Canada stands with the US, with Japan, with Australia, with Great Britain. I mean, I did my SJD on this topic. It's always the same actors, almost consistently,